Fee, thank you. Well, it is a great pleasure to be here. I actually live out this way, but I still got lost using the GPS to try to find Cabrini. I ended up on Windsor Court, and I'm looking around. I said, this doesn't look like a college. And I know I've driven by it, but I finally, fortunately, did get here. I'm also happy that it's the first day of March. February can't end soon enough for me. It's never a month, even though I like the 28-day concept. It's never a month that I find particularly enjoyable. So March has that sort of hope of spring, and except for this next snowstorm, hopefully that will be the last. Well, I've been involved in scleroderma for a long time, and part of that has to do with Sergio Jimenez. Sergio is a very good friend. We were at Penn together when I was training, and many of you have seen Sergio or been treated by him and know that he's one of the leaders in the forefront of the disease. And so when the first national scleroderma meeting was here a number of years ago down at the Hershey Hotel, I think it was at that point, I was involved with that relative to what we could do orthopedically for scleroderma, and subsequently involved in seeing patients from all over the world who have come to him, and often he'll decide they need something, and while they're visiting Philadelphia, they will often end up in my office as well. And scleroderma is worldwide, so that when I'm traveling and when they present difficult cases, as they often do, to kind of challenge the visiting firemen, it's often a scleroderma case with bad vascular problems and frozen joints that they like to see what we can do in America. And hopefully, as you'll see and feel by the end of this talk, we have made progress, a lot of progress compared to certainly when I started my practice way back when. Well, I thought I'd start the talk actually by mentioning Paul Klee. Paul Klee is a Swiss artist. Get my camera to work here. Is a Swiss artist and a painter who's one of the founders of abstract art. And if you look at his early paintings, what he epitomized was lots of color and almost children-like drawings with a kind of hope and dreams and music. And so you had pictures like this, Remembrance of a Garden or Dream City. In 1933, he was working in Germany, came back to Switzerland to escape the Nazi rise, but also around that time developed scleroderma. And here we see him in a picture 2 years before his death. If you look at his left hand where he's pointing at the drawing, his fingers are contracted. They're not just folded in there in a nice fashion. They are contracted. You'll notice that his face, if you remember the picture you just saw, his face is now relatively tight. He was having some pulmonary problems at this point. And as his hands became increasingly stiff, his painting became more difficult, forcing him to develop a sort of simpler, more linear approach to life. And we didn't have the same kind of drugs that we have now, or the understanding even that we have now, and so he died within 7 years of contracting the disease. And so here we see one of his earlier paintings, Tunisian Garden, that sort of almost kid-like thing, to one of his later paintings done right before he died called Death and Fire. And you can see how the lines have become bigger, how it has a sort of stiffness to it as a painting, and how he derived that. Well, classically in scleroderma, we've all been taught that if you look at the hand, which has, as a basic mechanism, knuckle joints, which we call MP joints, and middle joints, which we call PIP joints, it is these joints which bear the brunt in the hand manifestations and joint lesions of a scleroderma. And so at the PIP joints, it's one of flexion deformity with progressive bending into the skin, breakdown of the skin dorsally. At the MCP joints, it's extension, and so the hand becomes somewhat clawed in this fashion, making it difficult to pick up a bottle like this, and you need both hands to grab large objects, making it difficult to manipulate the small objects that are there, and that's the conundrum that we face. Well, if we go back, and I realize you all are becoming experts in this, getting a lecture every Saturday, pretty soon you ought to have a degree at the rate you're sort of being educated. And I don't mean to be too simplistic and repeat more sophisticated things that I'm sure Nora and other people gave you last week, but I think it is, certainly as a hand surgeon, I need to always kind of go over things a little bit. And scleroderma just means, as we all know, hands turned to stone, really from the Greek. And in fact, the first description of scleroderma that has been unearthed was in Hippocrates in 400 BC. So it's not something like AIDS that we suddenly found out about. It's been around. And the classic description, at least medically, was by Dr. Carlo Curzio in 1752. He described it in a 17-year-old girl who he writes had wooden skin. In those days, the treatments, you went to Venice for vapors, you got warm milk baths. We're probably going to bring that one back. That sounded pretty good. And then therapeutic doses of actually mercury, which is a quicksilver. But that was basically our understanding. One of the most famous physicians in America, Sir William Osler, really described the disease as he saw it. Again, without very much in the way of treatment. We're still in the massage. They felt that warm weather, they felt there was an infecting organism that was doing this. Obviously, autoimmune hadn't come into the picture. They certainly realized the vascular lesions, and you can see, he says, the hands become fixed and the fingers immobile on account of the extreme induration of the skin over the joints. Gradually, a diffuse brawny induration develops and the skin becomes firm and hard, and so united to the subcutaneous tissues that it cannot be picked up or pinched. The skin may look natural, but more commonly is glossy, drier than normal, and unusually smooth. Bullae, which are cysts, and ulcerations have been met with, in some instances, and a great deformity of the nails. So that was where we were in 1914. It was really Bob Getz in 1945 who really sought to try to understand it, wrote the first detailed description of systemic sclerosis, and noted its progression. The incidence, as we understand it anyway, is about 1 in 4,000. The peak age of onset is 45. Women, as they often do in many illnesses, bear more of a brunt than men. And we have essentially a number of organs, particularly in systemic sclerosis, which are affected from esophagus first, through lung, through heart, through kidney, and almost 100% of the hands, which makes my endeavors helpful. Some of the newer classifications, because the rheumatologic literature is trying to understand the variants and lump together as much as possible. We essentially have 4 variants now. Localized morphea, which is really hardened skin plaques as opposed to a diffuse area. The limited cutaneous type, which is crest. Diffuse cutaneous type, and finally systemic, which is characterized by small vessel problems, antibodies, as well as fibroblast dysfunction with extracellular matrix. And so here are a couple examples of morphea, that sort of hard, patchy areas, but are very, very localized, whether to the dorsum of the hand. We don't see contractures in this. The patches have been reported to resolve in some patients, though in some they tend to stay around. Certainly crest is what I see almost the most of, and it stands, as you can see, for calcinosis, Raynaud's, esophageal problems, sclerodactyly, and telangiectasia. And finally, diffuse scleroderma, which, again, fortunately is the less common compared to crest. They all tend to have skin involvement, hands involved. Raynaud's phenomenon, often in crest, may precede crest by many years. Telangiectasia are less common in the systemic forms. Renal disease, pulmonary fibrosis, pulmonary hypertension, and what Sergio and his team and Nora have been working with is obviously new medications which are effective at lowering pulmonary hypertension. Both types have the digital ulcers that we see. And so they're really, between the two types, there's no difference in sclerodactyly or digital ulceration. Also, it's extremely important for someone who's involved in surgery relative to scleroderma to realize that there is an increased anesthetic risk in those patients with diffuse scleroderma because of the pulmonary potentials. So that we're well aware of that, and so that our anesthesia in those cases is always going to be some form of what we call arm block or leg block, spinals, and we try to keep essentially a non-general anesthetic in those cases. Some of the classic pictures of what we see in CREST, the calcinosis, the sclerodactyly, the digital ulceration, and the obvious purple, blue, and white of Raynaud's. The critical thing, and obviously as a referral hand surgeon, most people I see have a rheumatologist involved in their care, but we really need to make sure that there is optimal management. And when I go on these mission trips, often there is no medical management. They come to the surgeon because of amputations or gangrene or lack of function, but they have no medical management, and it's extremely difficult to try to organize that outside of it, particularly university centers. And so surgery, as it always is a last resort, not something we choose as a first resort. As with all things, we have certain goals that are realistic. Our goal is to make sure you have a pain-free, functional hand. We want to avoid amputation if we can, and we would like to improve cosmesis secondarily. And this is where there's been some progress. If we look at a large series of Neil Jones, who's in California, if you look at the surgeries performed over about a 10-year period, 1977 to 87, he operated on 31 patients, and you can see that probably one of the most prominent procedures he performed was digital amputation for gangrene, and then some of the same procedures that we do today. Charlie Malone, who was at Special Surgery in NYU in New York, again, looking at a large series from those two institutions, done about 5 years later. The first thing you begin to notice is digital amputations are not very high on this series, and so we're beginning to move forward in what we do and what we can do to maintain function. In our series, looking at the last 10 years, we've done over 480 surgical procedures in scleroderma patients. And the general tenure is that sympathectomy, that is, as we'll see in a second, restoring the digital circulation to maximum function, has replaced amputation. Working in the hands themselves for hand problems has replaced operations, particularly when they were done up high in the cervical area. We now favor putting in new joints over trying to release tightness around the MP joints. One thing that has been a mainstay and continues is fusions at the proximal and distal interphalangeal joint levels, and then the critical emphasis on restoring thumb function and keeping a web space so that you can get around things. Scleroderma presents us surgically with some very unique problems. The skin obviously is quite tight, and so when you make an incision, we don't have the ability to what we call mobilize or move the flaps around because of this loss of gliding function of the skin. And so you have to design your incisions and your plan to take in mind the fact that you don't have that skin mobilization. And so one of the things that we've learned is better ways to make incisions and preserve the planes of function. Fusion angles, that is what position we place them in, and the types of bony fixation. And so we do generally get a successful fusion, particularly at the PIP and DIP joints. We usually average a normal arc of MP motion is straight, which is 0 in Dr. E's, all the way down to about 80, 85. We usually get an arc of motion with replacement of about 50 degrees, whereas our arc of motion prior with capsulectomies was in the 10 to 15 degree range, and so it increases that threefold. There are a number of things that digital sympathectomy has done and some new ways to do that, but in most people now we can get ulcer healing without gangrene or infection and overall aesthetic improvement. And so here we have that MP hyperextension hand, the fixed flexion of the joints with the decreased grasp. We're going to start off with essentially a fusion of the PIP joints. As I said, these are done under regional anesthesia or local, both of which are vasodilating, which we want in terms of a healing. And again, minimal dissection, particularly when the contracture, that is the drawing into the finger, is greater than a right angle. And so here we see a hand immediately post-op with fusions of those joints of the fingers, and at the knuckle joints. I have a pointer? Maybe? No? Yes? But of the, where you see the proximal incision, those are joint replacements. And down the road, the ability, therefore, to get around a bottle, to do functional activities. Oh, thanks, T. To get around functional things and improve cosmetic appearance. Again, going back to the MP hyperextension again, we want to try to increase the breadth of grasp, and that's where the MP motion is good. Remember that the palmar skin is almost always preserved, and one of the new things that we're looking at is, why is the palmar skin preserved? What does it have? Well, it has a great deal more fat, and so some of the newer work, believe it or not, and cosmetic surgery is playing an increasing role, is the use of fat transplants, vascularized or not, that may in fact change particularly surfaces like the posterior aspect of elbow, dorsum of hand and wrist. So, you know, we take it off one place, we'll put it somewhere else, and you don't have to pay a cosmetic rate. It's all functional. So, yeah, you can go wherever, and we have a reason to do that. But that is something that is new on the horizon. And so here we see the x-rays with the MP joints in hyperextension and the flexion deformities of our PIP joints, the sort of mantra. But the joints are still preserved, they're just hyperextended. And here we are replacing the joints. This is the spaces in here, little metal things we use, particularly on the index and long, to give you more power of pinch and stability, but we want motion at 4 and 5, so you don't see those sort of metal casings. You see the wires in the thumb where we've done a fusion to give the thumb pinch power. An incision looks like that. Here we are coming down into the, I hope these pictures aren't too gory. We've had our breakfast, but I don't wish to see anybody else's come back. We're now going to mobilize that skin and replace the joints and increase, as I said, to about a 50-degree range of motion. The thumb is also critical. It's 50% of what we do with the hand, and so web space contractures there are particularly disabling, and we make a big effort to essentially, as you can see here, replacing the bottom joint where you see that little black area and fusing the middle joint to give us power but also breadth of sweep to give us that abduction power. And in studying patients with DASH and a number of different instruments that we look at pre and post function, we found that basically there are substantial improvements in the patient's ability to perform ADL by essentially the procedures that you just saw. So the fact that we're not normalizing things, which is obviously our goal, but improving things, making pain generally not as much of a problem unless there is infection or at the PIP joint level, but just improving the overall function, that we can make substantial improvements in that is documented. There are overlap syndromes, which, you know, everything is not quite so pure these days. So this is the x-rays of a patient who has scleroderma and rheumatoid arthritis, a sort of mixed connective tissue. So now we see destruction of the wrist, which is unusual in scleroderma, along with contractures. And in this patient, because their wrist was extremely painful, we are going to do a fusion of the wrist. This is an earlier case, actually, from the early 2000s, but fusion, a very successful procedure. People say, wait a minute, fused wrist. We just talked about fused PIP joints. Well, it's the same principle. You want to get a stable unit so that the fingers can work around that and have good grip. A wrist that's down like this and flexed or unstable and painful isn't functional. So it takes out the whole hand, and by fusing the wrist, you stabilize that unit and allow better pinch and grasp function. There have been a number of series, however. One of the goals, you've all heard of total hip and total knee replacement, and now we can replace pretty much any joints. I mentioned the fingers earlier for the metacarpal phalangeal joints. The wrist has been particularly difficult to replace because there are 8 carpal bones and 44 ligaments. And so there just isn't a simple hinge like a knee, a ball and socket like the hip, a ball and socket like the shoulder, a hinge like the elbow, a hinge like the MP joints that really mimics the function. And so everything we've tried since the 80s has had one problem or another. Despite the fact that some of these earlier prostheses dating from back when, even though they didn't work very well, the patients, when asked, said, gee, even though I only got 10 degrees of motion, I like that 10 degrees of motion, particularly if they had a fused wrist on the other side. And so nowadays, we can replace the wrist. One of the new things over the last 5 to 8 years, we have developed wrist replacement. Here we are kind of sawing bones and fitting in a prosthesis, which you can see over there. And it's kind of a mimic. Instead of reproducing all 8 bones, we produce patterns of bones. And so by analyzing arcs of motion, we're able essentially to take a whole row of bones and replace it as a row rather than trying to think of each one moving individually. And that allows us to have a picture like this, the pre-wrist up above, and now you see the sort of space with the sort of metal things. And also what we found is that by preserving more of the bone, rather than just kind of clearing a big space and essentially resurfacing the interior of the joint, that we can maintain function. And so you see this patient with 2 total wrists, now able to wash her hands and essentially do things. You can see the motions maintained. This is a 2-year follow-up. We've studied these patients. This is one we've wired up for a study we're doing on wrist replacement. You can see she deals a pretty good game of blackjack. I'm not sure I deal with her, but overall, when we look at DASH scores, which are disability scores of the upper extremity, a DASH of 30 in a patient with significant scleroderma is a very good score because it takes in all the things you can't do, climb stairs, heavy lifting, etc. And so we do have now new things on the horizon, which are not just new like, well, let's try this. They've been out now for almost 8 years and are holding up as well as our colleagues who do hips and knees for this. One thing that has always been a question is, as we know, both major types of scleroderma have calcinosis as part of their repertoire, and CREST obviously starts off with the calcinosis. And as many of you who I know as friends and patients in this room come in, you say, it just hurts when I pinch against my thumb or my index finger. It's just a sort of uncomfortable fullness in the finger aside from the potential for drainage and for infection. Sometimes it's liquid, so here you see us opening a finger and it streams out like you squeeze a toothpaste tube. It literally is called the liquid type. Many, however, are fixed in the tissues and are hard, and so you have to scrape them out like a dentist would clean tartar off your teeth, or we use small little specially designed burrs to get this sort of harder calcium that you see in this patient. We've operated on a lot more than 9 patients for this, but no one has really studied this in great detail, and so we took 9 patients and did a study, and we were interested at, does it come back? And this study ran for 2 years, and all 9 patients were satisfied. As you can see, the majority have limited, because limited has a higher incidence with the CREST of it. But we were able to maintain without reoperation on the same digit function with less calcification. Digital ulcerations and ischemic pain from Raynaud's has been one of the major challenges because, as we said, the vascular pathology plays a role, particularly in the small vessels. And almost all patients with scleroderma will have some degree of cold intolerance with obviously a varying in intensity. And it has to do with the fibroproliferative changes that we see. Remember that if we look at a blood vessel, as we see here microscopically, unlike a plumbing pipe, it has a dynamic wall. That's that smooth muscle layer, and that smooth muscle can then open and close depending on whether you're in a cold environment or whether you're trying to sweat. And then it has a kind of thin endothelial lining and has those sympathetic nerve fibers. But one of the first lesions in Raynaud's phenomenon is that you get increased tone of these sympathetic fibers, which make this muscle constrict down. So it's always closed, and then when they get exposed to cold, it fires it even more, making that vessel narrower and narrower and narrower. And the longer it stays in its narrowed constriction state, the more narrow it gets so that it doesn't go back to wide open again. It only goes back to 60% open, et cetera. And that becomes a somewhat spiraling deterioration. And so here we see at a specimen taken out from a patient, this hypertrophy of the muscle and the lumen now almost barely a slit left in that vascular channel as opposed to a wide open vessel. About 70% who present with digital ulcers and Raynaud's will have ischemic pain at rest. We call that hand claudication. The more you try to use your hand, the more it starts to hurt. And then our major problem is we get infections, which can be difficult to treat because the antibiotics can't get there because of the poor circulation. We have a number of things that we do in some patients now, fortunately, at least in this country. Most of the patients that we see have seen a rheumatologist and have had some treatment relative to look at the vascular circulation of their hands. But now we look at how much the collateral circulation is present in the hand, what options do we have to revascularize the hand. We also now, in a laboratory, can do what we call cold stress test to kind of see how reactive is the sympathetic system to this. And so you see someone who has a control resting pulse on the top. We stick them in ice for 2 minutes, and essentially they have no blood flow in that finger. We then give them a block that's essentially a Novocaine to the nerve. So we've taken out the sympathetic function, and boom, they open up bigger than they did at rest position. So that we have ways to assess, is this a responsive? Now, some people will have the same at rest as they do in ice, and that's an end-stage problem, and then we have to do other things. We have essentially some extra circulation in our hands, which is good because sometimes the cardiologist and cardiac surgeons will borrow one of the hand vessels to replace one of the vessels in your heart. I think it should go the other way, but that's a hand surgeon perspective. But they'll steal one of the vessels, and they can do that because you have two, and those two, one coming in from the thumb side, which is where the nurse usually takes your pulse, to the other side, which has an ulnar. And in vascular disease such as scleroderma, you can lose one, as you see here, the radial artery out, or on the other side, the ulnar artery out. And that's important for us to know if we're trying to reconstruct an ischemic lesion. And you can get everything from gangrene, as you see on the left, to these little ischemic red ulcers that we see. Well, there are a number of drugs that have been tried, and they work on different things. We have vasodilators, which are trying to block that smooth muscle to expand it. There are those which are trying to nourish the endothelium, and there are those which are trying to increase perfusion. And they have a checkered history, and the reason there's so many is one may work well in one patient and not so well in another. And some of the experimental work we're doing is to see who is more likely to respond to a vasodilator versus some who are more likely to respond to a sympathetic inhibitor. But the other good news from plastic surgery, we talked a little bit about what fat may be doing in the future in some treatments of scleroderma. But one plastic surgery procedure has come over, and that's the use of Botox. Mike Neumeister, a plastic surgeon at Springfield, Illinois, had some extra Botox, and a patient who was having, I can't imagine why, because most scleroderma people look very young. They don't have a lot of wrinkles, but he was doing something with Botox in a patient. And there was some data to suggest that Botox is a sympathetic blocker, and so he tried it in this patient's finger with a digital ulcer when he was doing that. And lo and behold, the ischemic pain went away, and within a short period of time, the ulcer healed. And so doing something sort of doesn't make sense, but doing it, suddenly you found an answer. And a study was then instituted by a number of centers, and across the board, Botox now can improve pain in ischemic digits. It can improve ulcer healing. And so here we see a patient of mine with an ulcer of the right long finger, which had failed all medical management and was really sent, as you'll see for a second, for what we call a digital sympathectomy, which has been very effective at healing ulcers, but is a big procedure. Essentially, by giving an injection in the office, if we're there, by putting one here and one there on either side of the blood vessels to the finger. At 5 days, it doesn't look quite as red, if you will, though that may be exposure, but certainly by 3 months, it's fully healed. And this had been present for almost 9 months. So it does allow healing of ulcers. And so that has become sort of the mantra of the first line of treatment following the failure of oral drugs, and probably now is going to replace most oral drugs over the long haul. It lasts. The real question is, some people will get a year of relief from one Botox injection. We don't know why it should work that long. There are several mechanisms. Some people believe it paralyzes those little muscles in the blood vessels, allowing them to remain open. Some people think it has other effects on the sympathetic nerves. But suffice it to say, it's not something you do every 3 weeks. It's something that may be done once every 2 years. Simple things such as keeping your hands warm, keeping your neck warm. There was a study that came out of Britain where they just used mufflers, and they found that people with scleroderma who wore a muffler on their neck actually had less vascular spasm. Same patients that wear a muffler these 2 months, don't wear a muffler those 2 months, measured them, and lo and behold, the muffler at the neck level seems to trigger some of the sympathetics. Carpal tunnel is a very common problem that we see in hand surgery, but there is an association of carpal tunnel and Raynaud's phenomenon. Carpal tunnel is this area here at your wrist. This is the cross section. So you have a series of bones, the wrist bones, which sort of form, as you can see, this sort of wall and floors. And then you have a ligament here across the top. And in this sort of tight compartment, which runs from your distal forearm into your palm, you have all these white structures here, which are the tendons. There's one to the thumb and 2 to each other finger, making a total of 9. And this sort of dark structure right here is the median nerve, which goes to all the fingers except your pinky. And so what happens is the tendons get thicker. We do get some joint deformity. The skin gets tighter here, making the extensor tendons. This is the dorsum of the hand. And that then gives you an association of carpal tunnel. The blood vessels, which you see here, the radial and ulnar arteries, basically they start to get narrow as well, adding to the phenomenon. You can also appreciate, this is palmar skin up here. See all the fat? I mean, you got tons of fat. So why doesn't that get scleroderma involvement? It just doesn't, and that's why the fat etiology is being looked at fairly seriously. So the sympathetics, that is what dilates your blood vessels, most of them travel in that median nerve. So when there's pressure on the median nerve, that dials up the sympathetics and increases the symptoms of Raynaud's. And so there is this connection, and simply by opening the carpal tunnel, nothing fancy here, this is a local procedure in everyone. And here we see a nerve that is hourglassed, as we say, and narrow. And this patient, aside from having the vascular symptoms, had numbness, tingling, and a lot of night pain. That generally will improve that 100%, and it improves their Raynaud's symptoms about 82%. Well, starting as early as the 80s, looking at digital ulcers, people such as Adrian Flatt, who's a Scottish hand surgeon who moved to the United States and resided at the University of Iowa for 20 years, really began studying what could we do to preserve length and avoid amputations. Neil Jones, who I mentioned in an earlier thing about some of the procedures he was doing at UCLA, showed in laboratory animal models that by clearing off the sympathetic, just doing away with those nerves, in fact, you could significantly improve healing potential and decrease digital ischemia. And so trying to avoid that sort of gangrenous infected lesion and this kind of process, which has gone on far too long for us to do that, but you want to save as much of the hand and other fingers as you can. And so we're trying to prevent that and loss of digital length. And we have, as you see on the left side, this is what we call a complete digital sympathectomy in the hand. What we've done is we've opened the radial and ulnar arteries here. We've opened each of the blood vessels to each of the fingers. And at a microscopic view, this is the small 1 millimeter vessel. We're clearing off that surrounding tissue and going down to that sort of muscular coat to essentially take away the abnormal sympathetic control. When we have a situation, as we do often, where the radial artery, the ulnar artery is not functioning and therefore the hand is undersubserved, particularly if it's ischemic through the other, now we're doing in the hand, this one is a bypass graft where we're essentially bypassing the ulnar artery where it's things and going higher up in the forearm, which tends to have less muscle in your forearm artery, and using that and then running essentially a plumbing pipe back into the superficial transverse arch. In a study again that we did at our center, looking at recalcitrant ulcers, this is before Botox, but looking at recalcitrant ulcers, we were able to heal recalcitrant being failed medical management, some gangrene, some amputation. We were able to heal 34 of 36 within 3 months of digital sympathectomy. And so if you look comparatively over the time that that study was done, 1995 to 2000, you can see the number of amputations versus what we have in 201 to 205. And I didn't put this data on because it wasn't part of the study that we did, but 205 to 210, I can't remember an amputation in this country of a patient that's been referred that we couldn't salvage. And so, in conclusion, hand surgery relative to scleroderma has been helpful. It's been helpful in alleviating pain, improving function, enhancing aesthetics, and avoiding amputation. Going back to our artist who led us off on this talk, Clay's tombstone reads, "I belong not only to this life, I live well with the dead as with those not born, near to the heart of creation and others, but still too far." Well, we are still too far from an answer to scleroderma. There are a number of researchers in this area who are dedicated to solving this, and I really believe because it's so unique that it may in fact be the gateway to solve a number of the autoimmune diseases which are harder to pin down. Scleroderma is so specific and so defined that if we can solve the key there, I think that it'll open the pathway to solve rheumatoid arthritis, lupus, and some of the others. And so we listen to the voices of all of you to lead us there. Thank you. Yes.
May I have a question?
Sure.
With the Botox,
Yes.
how long has that, how many years has that been used?
Well, Mike first did it in 1998, and then it's papers, because one person does it in Springfield, Illinois, doesn't mean you get to do it everywhere. There have been 8 papers now which have corroborated that in larger series in multiple centers. And so since about 2005 now, it's available. Our problem with a medicine like that is that Botox is the darling of the cosmetic world. And in medicine, we use it in one other condition, which is muscle spasticity, cerebral palsy, for example, and certain spastic muscle conditions. The problem is that the FDA won't approve it for those conditions, even though those are the ones scientifically that have shown effectiveness. And so we're allowed to use it, but they make the patient pay for it as if it were a cosmetic procedure.
That was my second question.
And that's created a problem for us because, I mean, it is an expensive medicine, number one, and so that has been an issue. One of the ways that we get around it is if we're doing something else to you, taking out calcium, doing something else, we can use it in a hospital setting without that prepayment. So it's covered by insurance if you're done in a hospital setting, but not as an outpatient. So that's how we get around it.
All right, the other question to that is, since insurance doesn't pay for it,
Mm-hmm.
this is weird, but I don't think you know the answer, but I'm gonna ask it. Can you take it off your income tax?
That I don't know. You have to ask your accountant. But I mean, I think absolutely. I mean, if it's a medical expense, there are medical expenses which aren't paid for. I mean, my understanding is you can take any valid medical expense. You probably have to get a letter from your doctor saying this Botox was not for 2 wrinkles, it was for her Raynaud's phenomenon. And again, the Botox is now about, plastic. I have lots of friends who are plastic surgeons, but they can get the Botox for about $500 for 100 units. They sell it to you for about $2,000. But in medicine, when you're doing it for what I do, you do it at cost. So the most expense is $500. We have a number of medicines now for Dupuytren's, which has nothing to do with scleroderma, but it's a medicine which is a biologic treatment for contractures of the hand. And it's very effective medicine. The problem is it takes bacteria to make this enzyme. It's an enzyme which they have to make, has to be purified. The company actually that developed it is here in Wayne. And because it takes so long, the drug costs $3,500 a shot. That's just one drug, but it replaces surgery in many patients, and surgery at a minimum is $10,000 by the time you go into the short procedure unit, by the time anesthesia is involved, by the time you have recovery, by the time you have all the preoperative tests, where this is something done in the office. So there is some quid pro quo there, which insurance companies have recognized, and some cover it. Medicare covers it, but some insurance companies still won't. And who knows in this new era how we're going to separate all the Obama kind of issues from that. But, I think eventually Botox will be covered for valid medical reasons.
Thank you.
Yes?
One of your slides said it makes the sympathetic system makes us more prone to thrombosis.
Well, sympathetic system does a bunch of things. In a sense, it was interesting. It was named by Sir William Sherrington, and it's kind of a sympathy part of the nerves. It does cold intolerance. It does things that we don't think about, sweating, etc. Sort of like the automatic thermostat on the wall. And so it's in sympathy with how your hands are functioning in an environment. That was the concept. So the sympathetic system doesn't have feeling. It doesn't control muscles. It controls pain by some of the delta fibers, and it controls how much a blood vessel opens or closes. So if the sympathetic system is firing, your blood vessel is tiny. If it's not firing, if it's neutralized, your blood vessel is like wide open as it can be.
So I'm trying to understand, even though I kind of have a medical background, but I still don't understand why keeping my core warm makes my hands warm exactly.
Well, the muffler experiment in England and other experiments have shown that, remember, in the old days, back in the 70s, when you had ulcers, they didn't have microsurgery that we have now, and so they would work on the big vessels up here at your neck. And so you have a little computer chip up here which controls, it's called the stellate ganglion, and it controls the sympathetics to your hands. And so by giving you a stellate ganglion block up here, which we can still do with Novocaine, or what they used to do by going in and extirpating that stellate ganglion, the concept was they would keep you wide open. The problem that happened with that is it wasn't successful in a great majority of people because there were changes at the hands, and the sympathetics, which are sort of local. It's like the mayor down here is running town and the central government orders something. It doesn't always get down to the city level. The city level had a lot more to do with your blood vessels and your fingers. And so while keeping your core warm and by doing a sympathectomy does sort of set the plane, if you will, for things open, in fact, by doing it locally, you have much better control and much longer lasting control. Mm-hmm. Yes?
Dr. Osterman, when I went to my rheumatologist with my first digital ulcer, he put me on Viagra.
Yes.
And within 2 weeks, the ulcer was closed. I had to pay a lot of money for it because of my gender, but, and I know there are now female versions. Is there any research being done, or is that a fairly common practice?
It's a vasodilator. It goes in the vasodilator. It's a very effective vasodilator. In fact, it was originally designed as a heart medicine, not as a medicine to improve our sex lives or to help digital ulcers. So it was approved as a heart medicine. It got too effective. It dilated the vessels, and people who took it fell over. So they took it off the market fairly quickly with that as an indication, but they did notice these secondary indications. It was interesting, a number of years ago, we had patients, similar to you, who are male, obviously, which is less involved in scleroderma, but there are a couple of vascular diseases, of which scleroderma is one. The Dupuytren's that I mentioned has a vascular component, who said, I started taking Viagra and my hands are warmer. They don't X, Y, and Z. And so this was about 10 years ago, so we wrote the company that was doing Viagra and said, we'd like to do a study looking at hand circulation. We have a number of anecdotal stories from patients that it might work. And at that time, Viagra was so high on the hog because it was the only drug out there and they could charge, the earth, the moon, and the stars for it. They said, we're not interested in that. This is small potatoes. Then Cialis and a number of other drugs came along, and Viagra's share of the market fell to less than 20%. Now they wrote us back and said, we're kind of interested in looking at how it does in vascularity peripherally. Again, it's the same problem, a little bit easier to get approved than Botox, a little bit easier than Xiaflex, for example, but still you run into problems getting it approved. Most of the times you can get that approved now because, again, the literature is out there as a vasodilator. But yes, anything that's a vasodilator, and that's a very effective vasodilator. Yes?
I'm going through the same thing right now. It's back and forth with the company and my doctor and my pharmacy to put me on that drug. It's been approved. Now, what are the side effects going to be for that? Because I'm prone to having low blood pressure, and my doctors have already tried multiple blood pressure medicines on me, and I go down to like 90/60. I'm fainting and everything. I can't handle blood pressure. Will that affect me the same way?
Hard to say. All vasodilators and all calcium channel blockers are going to lower your blood pressure. I mean, they open the blood vessel. If they make the blood vessel more open, it's going to have less head of steam in it. So they all affect blood pressure to some degree. For reasons that aren't quite completely clear, Viagra, Cialis, and the Sudafed compounds affect smaller blood vessels before they affect larger blood vessels like the aorta and arches. So coronary arteries would be more of a concern than your blood pressure usually on those medications. But, I mean, the problem with medications and even surgery is that people respond individually. You can say 10 out of 10 people who took this did X, but if you're the one who took it and keeled over, the 11th keeled over, right? So there is a great deal of variability in human response to medications, and that's one of the confounding issues when we try to put a drug that works for everybody. But generally, it's a low effect on blood pressure compared to the beta blockers, alpha blockers, et cetera. Okay.